Hello and welcome to this VJ Hemonc podcast, where we'll be sharing the latest updates in chronic lymphocytic leukemia. In this episode, we focus on sequencing and treatment considerations when using BTK inhibitors in CLL. As the treatment landscape continues to evolve, clinicians are faced with an increasing number of decisions regarding treatment selection, sequencing strategies, and the management of resistance. While BTK inhibitors remain a cornerstone of CLL treatment, the growing availability of combination approaches and next-generation therapies is changing how these agents are used across the disease course. This podcast episode is part of a Spotlight On podcast series supported by AstraZeneca. The supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. Let's get started. Despite the durable responses achieved with BTK inhibitors, some patients will eventually require additional treatment. Jennifer Brown discusses current treatment options for patients whose disease relapses following covalent BTK inhibitor therapy, including venetoclax-based regimens and non-covalent BTK inhibitors.
So patients who have disease relapsing after covalent BTK inhibitors have two primary options: venetoclax-based option, or now a non-covalent BTK inhibitor option. I think we have more and stronger data for the venetoclax-based option, but certainly depending on patient preference or circumstances, and especially in older patients or those with more comorbidities, continuing with another BTK inhibitor may be easier. We certainly don't know for sure if there is a preferred sequence at present. I would say, though, that if there are BTK inhibitor mutations that have come out after the covalent BTK inhibitors, giving patients a break with venetoclax may potentially change that clonal architecture and give them a chance to get a longer benefit later from the non-covalent, but that's speculative at present. Right now, I don't think the non-covalent BTKIs really change the sequencing algorithm. We have such long, mature data with the covalent BTKIs that I think people should still choose those first for their CLL patients. But the emerging data with pirtobrutinib do look interesting, and we'll have to see what really comes out of that data in terms of the resistance mechanisms for pirtobrutinib.
Selecting the next therapy requires consideration of several clinical factors beyond disease progression alone. Gianluca Gaidano discusses how efficacy, tolerability, and individual patient characteristics influence treatment selection following BTK inhibitor therapy.
So we have actually two options. One option is targeting another pathway for CLL, that's the BCL2 pathway. So the option there would be with venetoclax rituximab based on the Murano study. That's a fixed duration regimen for 2 years. But then a more recent option is instead still targeting the BTK pathway, but with a different mode of action, different mode of binding with the non-covalent BTK inhibitors. And the one that we know best is at the moment pirtobrutinib, for which we have several clinical trials already available. And this is something we have to think of it as a really different mode of action compared to the covalent BTK inhibitors. The covalent BTK inhibitors target a specific cysteine in the BTK molecule, but instead the non-covalent, like pirtobrutinib, they establish different type of bonds, and so they are functioning also in patients with mutated cysteine. And I think that safety is always a priority, especially because the CLL population tends to be an elderly population with median age diagnosis 72, median age post-treatment 76. So it's important, and these patients have many comorbidities. So thinking of safety is very important, and the non-covalent BTK inhibitors have a very high and excellent safety profile, and we know that from several clinical trials, including the recent BRUIN 322 study that compared, in fact, in patients relapsing after covalent BTK inhibitors compared pirtobrutinib versus investigator's choice. The rate of atrial fibrillation was very marginal, so very good safety profile. Efficacy is always important also, and we don't have head-to-head comparisons between the two different options that we have. But with non-covalent inhibitors, we can also guarantee a very good efficacy to the patient.
Beyond efficacy, safety and tolerability remain central to treatment planning. Gianluca Gaidano discusses how increasing selectivity among BTK inhibitors has reduced off-target toxicities, particularly cardiovascular adverse events, and highlights the favourable safety profile of second-generation BTK inhibitors such as acalabrutinib.
The selectivity of BTKI is something that has been improving over time. So the first-in-class ibrutinib targeted many innocent kinases beyond BTK. The second-generation BTK, covalent BTK inhibitors were already, so acalabrutinib, zanubrutinib were already a bit more focused compared to ibrutinib. And then with the non-covalent BTK inhibitors, the profile of kinome targeting is even more selective. So there's a very high selectivity, which then translates in reduced side effects. And this is something very important from the biology of the kinome targeting compared to the safety profile, in particular for what concerns bleeding events, but even more important, I would say, cardiovascular events, and in particular, atrial fibrillation and flutter. Acalabrutinib has very high selectivity for BTK, and at the same time, it spares instead innocent kinases that are targeted by first-generation BTK inhibitors. And that translates in, and this is well known, in a reduced rate of atrial fibrillation or other cardiovascular events, in a reduced rate of hypertension also. And these are very important aspects in a population which is mainly made by elderly patients who already are predisposed to cardiovascular events. So this has been a major step ahead with acalabrutinib.
The clinical impact of improved tolerability is particularly relevant in patients who may be more vulnerable to treatment-related adverse events. Barbara Eichhorst discusses findings from the CLL-FRAIL study evaluating continuous acalabrutinib in older and frail patients with CLL.
We did a trial in a patient population which is usually not addressed in CLL, which were patients above the age of 80 years or having a high frailty score according to their own judgment. And we treated these patients with continuous treatment with acalabrutinib. And what the study results show is that the response rate and the PFS rates are really very remarkable on this elderly patient population. However, we do see that more than 1/3 of the patients are stopping the treatment within 2 years due to side effects, also showing how vulnerable this patient population is. For me, the most impressive results from this trial is when we look at the frailty score in the patients, and that we see that in nearly 50% of the patients, their own judgment on their frailty is improving while being on the treatment. And I think that's an important message when we look at an 82-year-old patient who is really very sick due to their CLL, that we do not suggest best supportive care, because some of his frailty may just be due to the untreated CLL. And at least I think that's what the study show, trying to treat these patients and seeing how the frailty is maybe improving. That's an important message.
These findings illustrate both the opportunities and challenges of treating older patients, demonstrating meaningful clinical benefit whilst reinforcing the importance of ongoing toxicity management. Professor Gaidano discusses the AMPLIFY trial, evaluating fixed-duration acalabrutinib plus venetoclax, an approach that builds on the favourable safety profile of second-generation BTK inhibitors.
So the AMPLIFY trial, in fact, have been using acalabrutinib venetoclax versus standard of care and documented the advantage. And that fixed a new paradigm, and that's the first actually fixed duration regimen with a second generation BTK inhibitor. Obviously, we would like to have a head-to-head comparison, which we don't have yet. In the case of acalabrutinib venetoclax, we have it for ibrutinib venetoclax fixed duration versus ibrutinib continuous treatment, because the CLL-17 study documented that clearly, but we don't have this type of evidence for acalabrutinib as of now. But it's obviously desirable to have, but in the meantime, I think acalabrutinib venetoclax will be an important, and actually already is an important tool for patients who, and that allows us to treat patients also a bit older than with IV because it's safer.
As fixed duration combination approaches continue to evolve, there is growing interest in whether they may also help delay or prevent the development of resistance. Kerry Rogers discusses how fixed-duration combinations of BTK inhibitors and venetoclax may help reduce the emergence of resistance while providing durable treatment-free remissions for selected patients.
So I think one way to overcome resistance to BTK inhibitors, and not just covalent ones, is to use these fixed-duration combinations of a BTK inhibitor with venetoclax or potentially anything else. Of course, venetoclax has been the most studied now, but sonrotoclax, other agents with a different mechanism. Because if, the covalent BTK inhibitors given as monotherapy are given for an extended period of time because they don't clear out residual disease and responses deepen out to 7 or more years. With these fixed duration regimens, you get a good reduction in disease, can stop them, and remissions are durable. And the data we have so far is that mutations associated with resistance are not seen at disease recurrence. So I really think this is a great way to limit resistance. Of course, the BTK inhibitor monotherapy is highly convenient and appropriate for a lot of patients, so this strategy might not be for everybody, but I do think that is an outstanding approach. I think we also have to see how these can be sequenced in populations of patients. There's a lot of things we don't know, like use of a covalent BTK inhibitor like acalabrutinib after pirtobrutinib, and hopefully that data will develop. You also, with the patient, could think about how many therapies they'd expect to have in their lifespan. I think that makes a difference as well.
Building on this concept, combination approaches are now demonstrating encouraging clinical activity in patients who have already developed resistance to covalent BTK inhibitors. Kerry Rogers discusses a long-term follow-up from a Phase II study evaluating venetoclax added to ibrutinib in patients with BTK inhibitor resistance mutations.
So I'm really excited this meeting to share long-term follow-up of a Phase II study we actually started quite a while ago. And the whole goal of this study was to take patients who were taking the covalent BTK inhibitor ibrutinib, which at the time was the covalent BTK inhibitor we had available, and at the time developing molecular resistance, actually add venetoclax to ibrutinib with the goal of eliminating molecular resistance and ideally giving patients some time where they didn't have to take treatment. Still today, for patients whose CLL progresses on a covalent BTK inhibitor, the expectation is that they'll be taking therapy most of the time. Even with approaches that are a venetoclax fixed duration there, the median PFS, which is actually unknown in this specific setting, is usually around 2 years. So you might get some time off therapy, but there's not usually long durations of time. So we chose venetoclax as the intervention because it was the most effective therapy in a covalent BTK inhibitor progression setting. And we saw that the variant allelic frequency, BTK mutations and PLC gamma-2 mutations would decrease with that compared to other therapies we treated patients with in that time frame after ibrutinib. And now, of course, it is known in lots of settings that BCL2 inhibitor, BTK inhibitor combinations are effective. But then we mostly just knew they were safe and could be effective, and it really wasn't as developed as a combination. So we had 28 patients that were taking ibrutinib generally for quite some time. And the eligibility criteria was that they had to have a resistance mutation that was persistent with or without progressive disease. They were also allowed to discontinue the combination of venetoclax and ibrutinib after venetoclax was added at either 12 or 24 cycles, so that's about 12 or 24 months, if they had a complete remission with no detectable CLL. What we found was the median progression-free survival with this strategy was 40.7 months, which is considerably better than the 24 months in a Phase II trial of venetoclax monotherapy. So that was a really nice improvement. We also had half the patients discontinued due to response. I will say that not all of them discontinued due to the exact trial stopping criteria. A lot of this took place during the pandemic where we couldn't do the assessments we wanted, or some patients elected to discontinue due to difficulty returning for visits at the height of the pandemic. But we did have half that were able to be off therapy. Many of them are still not getting treated at longer follow-up. And those that did start a subsequent therapy there was a median of about 22 months before they had to start a next line therapy. And those are people who discontinued due to response. We also saw that the median PFS for those who discontinued treatment due to response was better than those who discontinued due to progression, which, it's an exploratory analysis and this is a smaller study, but at least supports that stopping treatment in this setting is certainly feasible and isn't really adverse for the patients. So I really do like this strategy of doing this combination. We did see that a lot of patients became mutation negative, which meant there was no detectable resistance mutation, and MRD negative, so no detectable CLL. We did see return of some of those resistance mutations when the disease was again detectable or recurred. So I don't know that this is a strategy that will eliminate this molecular resistance to BTK inhibitors indefinitely, but certainly we can get deep remissions even in this space where people have molecular resistance. We did have a lot of the patients enter the trial when they had some signs of disease progression. So we had both in there, and we did kind of look at that as an exploratory analysis. And those who had the intervention before kind of markers of overt disease progression did have a slightly longer PFS. The last thing I really want to say about this is that I think this strategy is very valuable, and we're currently enrolling patients on a phase II trial of pirtobrutinib and venetoclax as a fixed duration therapy for patients who experience disease progression on a covalent BTK inhibitor, so ibrutinib, acalabrutinib, or zanubrutinib. So looking at this with a BTK inhibitor that is then effective in a resistance setting and venetoclax and having it be fixed duration for everybody. So I'm really excited about that trial too, because I think it builds on the success of this trial and is likely to be even more effective.
The next step is determining whether these combination strategies can improve outcomes in larger randomized trials. Matthew Davids discusses findings from the BRUIN CLL-322 study evaluating fixed-duration pirtobrutinib combined with venetoclax and rituximab in previously treated CLL.
So the current standard of care for previously treated CLL is venetoclax plus rituximab as a 2-year fixed-duration regimen. This is based on the Murano trial. And we know that from the frontline setting that there's great efficacy of combining BTK and BCL2 inhibitors. There's true synergy between that. And so we hypothesized that in this relapse population, if we added pirtobrutinib to the current standard of care, venetoclax and rituximab, as a time-limited fixed-duration regimen, that we would see significant benefit with respect to PFS. So the primary endpoint of the study, which is progression-free survival by an independent review committee, was strongly positive in favor of PVR over VR, with a hazard ratio of 0.54 and about a 15% absolute improvement in PFS with PVR at the 2-year timeframe compared to VR. Pirtobrutinib was also very well tolerated in this study. The drug tends to not have a lot of additional side effects, and so it became very feasible to deliver the triplet regimen even in older patients and those with comorbidities who are on the study. There were also several planned subgroup analyses, which I think are very relevant to the relapsed refractory population, in particular, patients who had previously had treatment with covalent BTK inhibitors. And in fact, this is really the first time that we've seen a robust data set for venetoclax-based combination therapy in a post-covalent BTK inhibitor population. And the magnitude of the benefit of PFS was actually even greater in the patients who had progressed on prior covalent BTK inhibitor with PVR compared to VR, suggesting that's a population that may particularly benefit from this new regimen. Similarly, patients with high genetic risk CLL, like those with TP53 aberration, had a significantly improved PFS with PVR. So based on this very favorable efficacy profile, along with the favorable safety profile, we hope that our study will actually define a new standard of care for relapsed refractory CLL, which would be PVR, that can be used across a broad population of patients.
Overall, treatment planning in CLL is becoming increasingly individualized. From selecting therapies after BTK inhibitor treatment to balancing efficacy and safety and exploring strategies to overcoming resistance, clinicians now have an expanding range of options to tailor care for individual patients. As new combination approaches and sequencing strategies continue to emerge, ongoing research will help define how these therapies can be integrated to further improve long-term outcomes. Thank you for listening. We hope you enjoyed this episode exploring sequencing and treatment considerations when using BTK inhibitors in CLL. To explore more expert insights and interviews in CLL, head over to bjhemonc.com. Be sure to follow us on X at bjhemonc and subscribe to our podcast on Spotify, Apple Podcasts, or Podbean. Until next time.